Hello, my name is Dr. Thomas. This is going to be the first case in a series of hundreds of challenging case studies in clinical medicine. Let me present the case first. Here we have a 28-year-old Caucasian female brought to the emergency department by her family due to altered mental status, palpitations, and high fever. Family reported that she has had symptoms of weight loss, anxiety, heat intolerance, and tremors for several weeks. Over the past 24 hours, she became increasingly agitated, febrile, and confused. With episodes of vomiting and diarrhea. These are the physical examination findings. Her vital signs showed a high fever of 104.2, heart rate of 148 beats per minute, irregularly irregular, blood pressure of 155 over 65 millimeters of mercury, respiratory rate of 26, and oxygen saturation of 94% on room air. Patient is agitated, disoriented, diaphoretic, and unable to follow commands consistently. On cardiovascular system examination, patient appears to be tachycardic with irregular rhythm suggestive of atrial fibrillation. No murmurs, rubs, clicks, or gallops audible. Examination of the chest revealed that the patient is tachypneic with clear lung fills bilaterally. GI examination showed hyperactive bowel sounds, no abdominal tenderness or hepatosplenomegaly. Examination of the central nervous system showed that the patient is confused, restless, with hyperreflexia in the upper limbs with no focal neurologic deficits. Skin examination showed warm, moist, flushed skin. And examination of the neck showed that the neck is diffusely enlarged with non-tender thyroid gland with bruit over both lobes. These are some of the relevant investigation findings. Patient's TSH is markedly suppressed with a value of less than 0.01. Free T4 and free T3 are markedly elevated. Complete blood count is within normal limits, and complete metabolic panel showed mildly elevated LFTs and slightly elevated blood glucose reading. Serial troponins are negative, and EKG showed atrial fibrillation with rapid ventricular response without any ST or T wave changes suggestive of ischemia or infarction. Of course, the blood cultures are pending. Thyroid ultrasound showed diffusely enlarged thyroid gland and hypervascular thyroid with no nodules. Chest X-ray showed clear lung fills, no infiltrates or cardiomegaly. CT scan of the brain without contrast showed normal findings, mainly done to rule out central nervous system causes of altered sensorium. Birch-Wartowski point scale score 75. Any score above 45 is highly suggestive of thyroid storm. The following are the main differential diagnoses. At the top of the list is thyroid storm or thyrotoxic crisis. Of course, you need to rule out sepsis with underlying thyrotoxicosis, pheochromocytoma crisis, neuroleptic malignant syndrome, but in this case, less likely because the patient is not on any antipsychotic medications. The last, not the least, is serotonin syndrome, unlikely because patient is not on any serotoninergic medications. So what is the final diagnosis? So the final diagnosis is thyroid storm precipitated by patient's non-compliance with antithyroid medications and recent infection in a patient with history of Graves' disease. It is often precipitated by an acute event such as thyroid or non-thyroid surgery, trauma, infection, an acute iodine load, or a parturition. The classic symptoms of thyroid storm include tachycardia, hyperreflexia, central nervous system dysfunction, including agitation, delirium, psychosis, stupor, or coma, and gastrointestinal symptoms such as nausea, vomiting, or abdominal pain. In 1993, Birch and Wartowski introduced a scoring system using precise clinical criteria for the identification of thyroid storm. A score more than 45 or more is highly suggestive of thyroid storm, whereas a score below 25 makes thyroid storm unlikely. A score of 25 to 44 is suggestive of impending thyroid storm. While this scoring system is likely sensitive, it is not very specific. You have to use your clinical judgment. So the management plan includes management of airway. Of course, the patient needs to be in the ICU setting. And this patient is clinically stable and no intubation required as she is able to protect her airways. And monitoring includes cardiac monitoring, temperature control, and frequent neurochecks. So the treatment of thyroid storm or thyrotoxic crisis is a stepwise medical approach. You give non-selective beta blockers such as propranolol. You can also use esmolol. Propranolol is typically given as 60 milligram dose orally every 4 to 6 hours or IV as needed. The advantage of using propranolol is that it decreases peripheral conversion of T4 into the active form of T3. The next in line is thionamides to block hormone synthesis. That's the mechanism of action of thionamides. That includes propylthiouracil and methimazole. We prefer propylthiouracil in this clinical setting because propylthiouracil also inhibits conversion of free T4 into T3. Typically, we give 600 milligram loading dose followed by 200 milligram every 6 hours. The next medicine to use is potassium iodide solution or Lugol solution 1 hour after administration of PTU. And there is a very important thing to remember is avoid giving PTU. Avoid giving iodine therapy before PTU to prevent iodine-induced hormone synthesis. Next in line is glucocorticoids, preferably hydrocortisone or Solucotref, 300 milligram loading dose followed by 100 milligram IV every 8 hours. You can also use dexamethasone or solimetrol. Of course, supportive care includes use of antipyretics, IV fluids, electrolyte correction. Keep in mind, avoid to use aspirin because aspirin may displace thyroid hormones from binding proteins. Next, but not the least, is identifying and treating precipitating factors. Always look for precipitating factors like infections, trauma, surgery, myocardial infarction, stroke, etc. etc. Course and monitoring. In this case, the patient felt significantly better over the next 72 hours. Fever abated, heart rate slowed to less than 100 beats per minute, with propranolol, and mental status improved significantly. Thyroid hormone levels began to trend down. Now, patient is ready to be restarted on methimazole 20 mg BID for long-term management after storm resolution. Patient should be referred to an endocrinologist for follow-up to evaluate for definitive therapy such as radioiodine ablation or thyroidectomy. These are the important clinical pearls. Thyroid storm is a clinical diagnosis and it is a medical emergency. Do not wait for labs to initiate treatment. Very important. Use Birch-Wartowski point scale to avoid to aid diagnosis, though clinical suspicion should guide action. PTU is preferred initially over methimazole in thyroid storm due to its inhibition of peripheral T4 to T3 conversion, as we mentioned before. Iodine therapy should always follow use of PTU or methimazole to prevent exacerbation of hormone synthesis. Beta blockers not only control symptoms but also reduce peripheral conversion of T4 to T3. Always search for and treat a precipitating factor such as infection, surgery, withdrawal of medications, or trauma. Mortality from untreated thyroid storm exceeds 20 to 30%, so early recognition is life-saving. Long-term management should be planned after stabilization of the patient. Radioiodine or surgery for definitive control of hyperthyroidism. The following is the list of references. Thank you for listening and subscribe to my channel.